Good afternoon, friends. Thank you for joining us for the session today. We'll be starting soon. Meanwhile, while you are waiting, there is a pre-test link in the chat box. You can start attempting it. For some of you who are writing that there is no audio earlier, I hope you are able to hear me now. If you're still having some problem, check your device setting, and maybe you can also try re-logging, log out and re-log in. Sometimes this problem goes away. I hope you have all got the pre-test link. As you know, this is the 12th session. This was the end of the third series of this monthly webinars uh, being conducted jointly by DSP RUD and NHSRC. Today is the last session. And you know, those of you who have attended earlier sessions, you already know the format of the sessions. For a certificate, those of you who are interested in getting the certificate for participation in this webinar, the criteria is that you must attend through the session as well as undertake both pre and post test. Some of you keep writing to us that you haven't got the certificate. The reason is perhaps either pre-test or post-test was not given. So this is a requirement for issue of the certificate. So please make sure that you give both pre and post-test. And sometimes you also say that you have taken both pre and post-test, still you haven't got the certificate. But make sure that you log in with the same email ID, because at backend we cannot make out. You may be having 2 or 3 email IDs. We cannot make out whose email ID is. So sometimes difficulty arises because of this issue. So use the same email ID that you use for registration, and for both pre and post test, same email should be used. And also, those of you who have missed the previous sessions, there is a YouTube channel of Quality and Patient Safety Division of NHSRC. You can visit that, go to YouTube and access all those previous sessions on this YouTube. And if you have any queries, you can write to, there is a email ID from NHSRC. You can write to them about if any issue about the issue of certificates. Good afternoon, Dr. Patni.
Good afternoon, Dr. Sangeeta. How are you doing?
Good, all well.
All
Today.
well. It's always a pleasure to join you in this STG webinars.
Yes.
We have been doing it for the last 3 years with your support.
Yes.
Um, and
Today is the
it
last session.
does.
Today is the last session of this series.
This is the last session of the current series. And
Yes.
of course, after the break, we will be restarting it with a fresh set of topics.
Yes.
We already have around 200 people who are logged in. And as has been the experience when the webinar starts, this number goes up, and 300, 400, 600, 800, depending on the subject and the availability of people. It keeps rising up as we go along. Uh, do we have the faculty online at the moment?
Yes, today I'll be taking the first session, and then Dr. Romit Saxena will be joining us soon. So I think I can start off with the session.
Right, right. So,
A very good afternoon to everyone. I, Shreya Srivastav, on behalf of Quality and Patient Safety Division, National Health Systems Resource Center, New Delhi, extend a warm welcome to Dr. Rajiv Patni sir, Advisor, Quality and Patient Safety Division, NHSRC, Dr. Sangeeta Sharma ma'am, Professor and Head, Department of Neuropsychopharmacology, DSPRUD, and to all the participants to the 36th session of STG series. I also would like to welcome our guest speaker, Dr. Romit Saxena, Professor Pediatrics, Lok Nayak Hospital, New Delhi. Standard treatment guidelines, also termed as clinical guidelines and clinical protocols, are component of health services provisioning to ensure evidence-based medicines and quality of care. At health system level, it helps in planning and costing of services. Standard treatment guidelines also become important tool for monitoring and authorizing procedure in a public funded health insurance schemes. With this quality control, regulatory, and planning functions, standard treatment guidelines become indispensable tools both for public and private service providers. Understanding its importance, NHSRC and Delhi Society for Promotion of Rational Use of Drugs came up with webinar series on standard treatment guidelines, also known as STG, as a learning platform for awareness and educating the healthcare professionals across the nation. Today's discussion is focused on antimicrobial stewardship along with identification of danger signs and symptoms of communicable diseases. Antimicrobial stewardship ensures medicines are used appropriately to prevent resistance and protect patient safety. Its effectiveness depends on the timely identification of danger signs and symptoms of communicable diseases, which helps clinicians distinguish cases that truly need antibiotics from that those do not. By linking early clinical recognition with rational treatment, healthcare providers can deliver safe, more effective care and reduce the spread of resistant infections. With this, I would like to request Dr. Rajiv Patni sir, Advisor, Quality and Patient Safety Division, NHSRC, to please brief the gathering about the objectives of this lecture series. Over to you, sir.
Thank you, Shreya, for your uh, very warm introduction and welcome to our faculty and participants. For those who have joined us for the first time, it's a reminder that this series of webinars is brought to you by National Health System Resource Center, which is a think tank and a technical advisory body for the Ministry of Health and Family Welfare. And we are joined in this venture by Delhi Society for Promotion of Rational Use of Drugs, DSPRUD, an NGO in the forefront of promoting rational use of medicines and improving accessibility, availability of drugs. So we all know that the misuse of antibiotics is a global problem, and especially in the slightly unregulated markets, it becomes it takes on a very significant uh, volume and a critical mass, which becomes difficult to control after some time. A common thing that you must have heard, especially those in medical practice, is I had a tummy ache or I had a fever. My brother was taking Augmentin, so I also decided to take Augmentin. My brother got well with Augmentin, so I also took that. And we all know that it doesn't work like this. Irrational use of antibiotics is something that happens at the personal front without professional oversight. However, even in professional surroundings and circumstances, such as in healthcare setups, in hospitals, in nursing homes, because of various reasons, sometimes antibiotics and other medicines, and it's not just antibiotics and other medicines could be overprescribed or underprescribed, and both are equally problemsome. So we need to understand that the antimicrobial resistance is rising globally, and in fact, WHO has recognized it as a challenge to be addressed across the world. And to talk about this subject, I have immense pleasure in welcoming my colleague, Dr. Sangeeta Sharma, who is not only helming and is the president of the Delhi Society for Promotion of Rational Use of Drugs. She herself is an expert in the field and has been working to promote rational use of drugs for the last several years. Uh, Coming along with her, the next faculty, it's my pleasure to welcome Dr. Rometh. Dr. Rometh will be talking to us about identification of danger signs and symptoms of communicable diseases. So, what we need to understand is that antibiotics, in most cases, are not required in viral conditions, let's say. So, and children have a very, very low therapeutic window. The margin of error is very, very low in children. So it becomes critical to recognize the signs, the danger signs, the red flags, the danger symptoms, so that they can be addressed appropriately. So Dr. Romit Saxena, a pediatrician from Lok Nayak Hospital, will be joining us for conducting this. Uh, for those who have joined later, I can see the numbers edging towards 300 now. For those who have joined us later, I must inform you that the participants who complete the pre-test and the post-test successfully, completion is not enough. You have to complete it successfully. They will be awarded digital certificates. We do have a robust process of evaluation of the pre-test and post-test sheets, and we do award these certificates. We have awarded how many certificates till now? Uh, so more than 4,200 certificates have already been issued over the last 2.5, 3 years that this webinar program has been going on. So there is a robust process, not everyone just for participation, but pre-test and post-test. And the good news is that we are in talks with the Delhi Medical Council to uh, to award credit points, CME credit points to the webinars in this series. So the next avatar of the webinar, when it appears again in the new year, will have, hopefully by the time we will have the approvals, will have the credit points for continued medical education. So I urge all the participants to strongly to engage with these STG lectures and the faculty, as they play a vital role in improving the healthcare delivery. And I wish you all the best, and I thank the faculty for joining us. Over to you, Shreya.
Thank you so much, sir. With this, I would like to invite our first speaker, Dr. Sangeeta Sharma ma'am, Professor and Head Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences, New Delhi. She is the honorary president, Delhi Society for Promotion Rational Use of Drugs, an NGO in the forefront of promoting rational use of medicines and improving accessibility, availability of quality drugs since 1996. She has conducted close to 200 to build capacity for doctors, nurses, and pharmacists. Dr. Sharma has a rich and diversified professional and managerial experience in health. One of her pioneering work is book, namely Standard Treatment Guidelines, a manual for medical therapeutics. Today, she is going to take up the session on antimicrobial stewardship. Over to you, ma'am. Ma'am, you're not audible.
Thank you, Dr. Patni, for your warm welcome and introduction to the sessions, the background, why this topic was chosen. Thank you, Shreya, for your kind words. Can I share my screen? Yes. Do you see my screen?
Yes, ma'am, it's visible.
Okay. I switch to full slide mode. Okay, today we are going to discuss very important topic, and I think this topic is central to all specialties. And we all agree that the antibiotics are the most important discovery of this century. All achievements today in modern medicine are because of these antibiotics. And even today we do see a lot of infectious diseases in both our outpatient department, inpatient department, and each one of us use these antibiotics. And if the foundation, as we know, that was laid down in 1940 by discovery of penicillin. Thereafter we had a subsequent number of discoveries quickly happening. Lot of new antibiotics were introduced. I call this as a golden age of antimicrobials, because earlier people were dying because of the without these antibiotics. So for we have now a very good armamentarium of these antibiotics available with us. And but something alongside the discovery of these new classes has happened that is worrying us, is that of course the number of deaths due to infectious diseases declined significantly after these antibiotics. But of late now, the number of deaths due to infectious diseases is rising. And if you see the red line here, this depicts the number of new antibiotics. uh, as long as it was going up, the number of deaths were going down. But now you see that this red line of number of new antibiotics coming to market is declining, but the rate of death of morbidity is increasing. This is all because of the resistance developing to these antibiotics. After 2000, for nearly 2 to 3 decades now, we haven't had a new antibiotic available. All we you may be seeing new drugs coming in, but these, remember, these are the generations. You will find generation of cephalosporin, generation of fluoroquinolones, like that, but no new class of antibiotic is being discovered. So this is something very worrying. So that shows, signals the need for preserving the existing antibiotics. Now, why do we need to preserve? This is because of the antimicrobial resistance. The resistance, if let me give you the definition here, that please clarify this. Many people have wrong misbeliefs about the AMR. They think that something goes wrong with the human body, or something goes wrong with the drug. That is why the patient do not respond to antibiotic. No, it is nothing of that sort. It is the germs ability, the microorganisms ability to overcome, to stop responding to an antibiotic, antimicrobial agent, for that matter, because this is seen with bacteria, seen with virus, seen with fungal, and even in parasites this is seen. So effectively it means that even in the presence of these antimicrobial agents, the pathogens, the microorganisms, they multiply and keep causing the harm or infection in the body. And impact of this is that the standard treatments become ineffective. Even if you give antibiotics, the patient remains infectious. Uh, uh, Infections persist, and can spread to others. And because these antibiotics are used in both human sector, animal sector, for food productivity, they enter into the environment. So it is a very, very complex problem now, because these are being used everywhere. But at the same time, remember that AMR is a natural biological phenomena. It is nothing new that we have discovered. Even at the time of discovery of penicillin, uh, Alexander Fleming noticed this phenomena. This is a defense mechanism of the microorganisms to overcome these antibiotics. In fact, these microorganisms have been on this universe even before we came, and our body is all occupied by these microorganisms. Of course, not all of them are bad bacteria. 90% are good bacteria, which are lining our gastrointestinal tract, nasal mucosa, lung lining, skin. They are manufacturing vitamins. They are helping us with the digestion. They create a barrier for the pollutant, infectious agents to enter into the body. But because of the indiscriminate use of these antibiotics, what we do is we harm these, damage these, or kill these good bacteria as well. So that is why it has become a major problem for us. Now, this, why is this? If it is a natural phenomena, why are we concerned about it? Because overuse, misuse of antibiotic accelerates this process of development of resistance. It makes it faster. स्पीड बढ़ा रहा है उसका AMR रेजिस्टेंट बैक्टीरिया का और ऑर्गेनिजम्स का. दिस इज बिकॉज ऑलमोस्ट, अगर आप, इफ यू लुक एट योर ओन practice and others practicing in your region, you will find more than 90%, 80 to 90% of all outpatient visit patients, they are receiving antibiotics. If you it comes to IPD inpatient department, nearly half of the patient are receiving these antibiotics. And sometimes we are using, when indicated, these antibiotics, we are using a broad spectrum antibiotic here, where a narrow spectrum of antibiotic could have helped in fighting the infection. And also, the prescribing is not in accordance with the standard clinical guidelines. And of course, patients are also self-medicating, taking doses incomplete, duration not completing, some people taking for more than required time. But at the end of the bottom line is, we are using these prescriptions, copious prescriptions, they worsen this resistance problem. There are 9 common areas for improving antimicrobial prescribing. Over prescribing, for prescribing for example, viral illnesses, upper source, respiratory tract infections, watery diarrhea. We all know these are all, mostly 90% are because of these viral infections. But somehow, either we are not able to distinguish between viral and bacterial infections, or under some pressure, patient's pressure or fear, we are overusing these antibiotics. Post viral cough, after influenza like illness, many times this post viral cough stays. So if many of us think that this cough is because of the infection continuing, so we prescribe antibiotics. So, and sometimes when you need a narrow spectrum antibiotic, we use a broad spectrum antibiotic, or we give it by wrong route, wrong dose. These patients, or sometimes we are so overcautious that we give double cover. We choose antibiotics, two antibiotics to cover for gram negative infection. So this is called redundant cover. This is not going to help us. And of course, there are several irrational combinations which are not justified. There is no rationale behind it, but they are available in the market. So, there is a temptation to use these irrational combination. I'll come to that. Then another one very important two things: omission or delayed dosage. This happens every time. Actually, if you look at the functioning in the wards, these antibiotics are to be given in on an hourly basis, 6 hourly, 8 hourly, 12 hourly, 24 hourly. But in practice, we reduce them to BD, TD, or once a day, but this is not true. So, and delayed doses can danger that the minimum inhibitory concentration of this antibiotic in the blood will go down and will make the bacteria start multiplying again. So wrong dose interval, we don't think about it, but these are also very important reasons for spread of this antimicrobial resistance. Now the question before us is, can you halt it? Can you stop this phenomena of antimicrobial resistance? As I said, this is a natural biological phenomena, so we cannot stop it. That must be very, very clear to all of us. We cannot stop it, but we can only contain it. We can only slow down this process. Thinking that no action today will take care of the tomorrow uh, is a pure gamble here, because as I told you, no new antibiotics are coming in, pipeline is running dry. So we need to only depend on the existing antimicrobials. But if we don't handle them with care and we misuse them, overuse them, perhaps tomorrow we will not have anything to manage these infectious diseases. So it is very important that we give a priority to prevent infection, because more the number of infections, more are the opportunities or temptations to prescribe antibiotic. So if we are able to prevent infection, that should be our target. And somehow, if still infection happens despite all precautions for spread of infections, containment is the next best option. Containment here, I mean that you need to control the spread. If outbreak happens, we need to contain it so that it does not become an epidemic, and the epidemic does not become a pandemic like COVID that we had. So we need to be really very careful about this. So containing AMR therefore requires an integrated approach where you have this antimicrobial stewardship, infection prevention and control, and diagnostic stewardship. Because most of the time we all understand this IPC, we are all trying to implement this in wherever we are working. But diagnostic stewardship, you may not know, but this is because if you make a correct diagnosis, if you are able to identify the pathogen, if you are able to identify the microorganism, perhaps you will choose a targeted therapy, so you will be successful in your treatment. But if the diagnosis is not made, but for good diagnosis to be made, we need to take samples. There are techniques for sample taking, storage of sample, transport. So many things can go wrong at each of these stages, and that is why you may not be able to identify the correct microorganisms. You may grow contaminants, colonizers, and we interpret it wrongly. So if wrong diagnosis is made, of course the wrong treatment would be there. So we need to, besides this antimicrobial stewardship, we need to look at these two stewardship as well. Anyway, each of these is a very session on their own. I'll be today focusing on the antimicrobial stewardship, and my focus would be what can you do. I will try to give you some of the examples. What are the choices that you are available to you? No, if you have to define what the stewardship means, is stewardship is just the coordinated interventions. Here we, when we talk about antimicrobial stewardship, we are talking about two things here: prevention of spread of infection and reduction in the use of antibiotics, antimicrobials. Reduction. We are not saying don't use antibiotics. Please mind this, we are trying to optimize the use of antibiotics. When I say optimizing, I mean when you need it, you must get an antimicrobial agent. But when not needed, it is a viral illness, or self-limiting illness. If you don't need it, don't give these antimicrobial agents. And this is true for both human sector and in animal sector. One more thing that which is adding to this AMR is that these antibiotics are not only used in human sector; they are used for animal, because they also fall sick. They also get these infections. They need these antibiotics. But the worst part is that to promote growth, fast growth of these animals, chickens, they are grown just for farming, for the meat. They are fed with subtherapeutic small doses of antimicrobial agents. They are fed with this to fasten their growth. So that is something is also, then antimicrobial residues remain in the these meat, and then when we consume this, so that's how we get this AMR. So we need to look at it holistically. But certainly today I'll be talking about things which are under your direct control. So in simple words, if I have to describe antimicrobial stewardship, it is a marriage between infection prevention and control and antibiotic policies. Antibiotic policies, all of you who have undergone this NQAS certification, you know that this is one of the mandatory requirements, that the facility should have an antibiotic policy. The objective of this antibiotic policy is to optimize the use of these antimicrobials. So, but uh, thing which worries is that these two remain isolated. They are not talking to each other. And infection prevention control people are working on their own in their own department silos, and they are not talking to the antibiotic policy development people, or this antibiotic policy is not implemented at ground. If one of the, you must have observed, when the external assessors go, they ask the staff over there whether they are aware of this antibiotic policy or not. Most often we find that people are not aware. It remains confined to those people only who developed this. So the stewardship, is that everyone knows about it, because it is the prescriber at the ground level, resident doctors, their medical officers. They are the ones who are prescribing, so they should know, what are the rules about prescribing of antibiotic in their facility. So antibiotic stewardship is like you can think of it as like a air hostess. Like air hostess takes care of all the passengers, right from the boarding, pre-security arrangements, coordination with the pilots, monitoring and evaluation during the flight, responding to the request of the passengers from time to time. So similarly, the stewardship requires that we get different types of patients in our settings. Some are very sick, some are, we need to foresee what are the different types of patients getting, what are they going to get, what will we do if they don't respond, or their condition deteriorates over a time. So stewardship is about coordinated interventions, and then you need to do the surveillance to find out what is the extent of this problem, whether the policies and guidelines are in place, and if they are in place, whether they are being followed or not. So the goal, ultimately goal is, I don't, if you don't remember the definitions idea, just forget about it. Just remember that the goal of this stewardship program is to reduce AMR. And how will we do it? By optimal use of antibiotics by all providers. I'm not only saying clinicians, nurses, pharmacists, each one of us have a role. Doctor's role is prescribing. They should first prescribe it properly. Then the nurse's role come in administration of these antibiotics, the timing, missed doses or omission, or the monitoring of the patient, whether patient is responding to the antibiotic or not, the duration of treatment with antibiotic, the duration of catheterization of the patient, because these are the external sources from where the patient is getting infection. So nurses have a role, pharmacists have a role, because they need to provide these medicines uninterruptedly. If the patient is infectious and needs a treatment, then the supply also should be matching, and also they can play a role in coordinating between the clinician, nurses, and the requirements of the patient. They can educate the patients. So each one has a role, and this will be done only if we do the right drug, right dose for a right duration, and de-escalate at right time. I'll explain to you about the de-escalation. So there are certain core elements of the stewardship program. Of course, it needs a leadership and a commitment from your boss, topmost person in your health facility. They have to understand that this is a major public health problem that we are all facing. We have all survived the COVID time. We know how havoc can be created by the infections, and if we are not able to control it, see, if you look at the number of deaths caused by AMR, they are much, much more than the total deaths being caused by COVID. It is estimated that by 2050, 10 million people will each year will die because of this AMR. So many of us, call this as a silent pandemic. We are not realizing, but we have already entered into this pandemic. So we need leadership and commitment here. There are certain AMS actions which are required, and for this, education and training and monitoring and surveillance is also required. That is why this session topic has been chosen today, to apprise about you all about this problem, how this because each one of us is accountable, responsible. We can't say I'm doing it because somebody is doing it, or somebody else is not doing properly, so it gives me a license to do it wrong way. No, it is not like it is. All of us have a shared responsibility to see how can we optimize the use of antimicrobials. Amongst the core strategy in stewardship is that we should follow the standard treatment guidelines. Antibiotic policy is nothing but rule book which decides which patient, which type of patients get a particular antibiotic, for how long, who can prescribe, how the samples, when the samples for microbiological diagnosis be drawn. So rule book talks about that. Uh, then there are certain things that I was looking at the profile of the people who took the pre-test today. Many of you are CMOs and quality officers. So we can do something at the hospital level, health facility level as well. For example, formulary restrictions, audits, you are all aware of this. There has to be a multidisciplinary AMS team should be there. I'll be talking about this formulary restrictions in detail. Supplementing these is that we de-escalate the therapy based on culture results. Dose should be given properly. Patients should be switched from intravenous therapy to oral therapy as soon as possible, as soon we find see that it is safe for the patient. Then there are other things. We need a multidisciplinary team for this. Here clinicians should take active part in it. Surgeons, those of whosoever is prescribing antibiotic could be part of this stewardship. Nurses, pharmacists, infectious disease specialist, if you have quality personnel, should be part of it. Microbiologist should be there. Administration people also should be there, because some of the decisions for procurement supplies are taken by the administration, and in addition you may require more resources for carrying out these audits. So it is good to have administration people along with you. So these, as I said, at the hospital level, what you can do is to follow guidelines, for make a policy. But this rule book should not be just a document to be shown to the assessors, but it should be practiced as well. This will be practiced only when we introduce this to our residents, the junior doctors. Most often they don't know, have no idea about the aim is to, we want to protect the broad spectrum antimicrobials, because they are the ones which save the patient. If the patient is suffering from some life threatening infections like sepsis, when they present to us, postpartum septicemia is a real cause of death, that we see very often. So then specimen, how we collect these specimens, when, where, which patient, how, all these things are very important. We often delegate this task to nurses, but often the right way of collection remains neglected. So guidelines, you are aware that ICMR has guidelines developed. They have recently added, got this infectious disease syndrome guidelines. Before that, NCDC also had this. We also have been having these guidelines since 2002. This is now in 7th edition. We have special sections for stewardship now. We have sections, we give pearls for practice, what is the right way of doing with each infectious disease that we cover in the guidelines. So you can consult any one of these. There is no need to reinvent the wheel. There is no need to make a fresh guidelines. These are already available. You just have to see which one suits you more in your situation. You can adopt and follow these. Now, coming to formulary restrictions, this is nothing but here this is a managerial approach. Here you classify the antibiotics into three categories. For example, that these are the antibiotics which will be available in the outdoor department. These are the ones which will be used in ICU, and these are the ones which will be used in inpatient setting. So that you restrict the availability either according to the indication, or you may say only the senior doctor can prescribe the broad spectrum, or you can divide, restrict the availability according to the services, as I said, or patient population, or you may use a combination. But idea is that some restriction is applied so that it is not overly used. Now, when this combined with pre-authorization, it serves a very good purpose. Pre-authorization means pre-approval of orders before dispensing. Sometimes in some hospitals they say the broad spectrum, like piperacillin, imipenem, carbapenem, drugs like these, when you have to prescribe, the consultant or the senior doctor has to write for it. So this is called pre-authorization. But in pre-authorization, sometimes because these consultants, senior doctors are not available round the clock, the patient may come to you in emergency at night. The patient is very sick, it is a life threatening situation, so you may have to use these high end antibiotics immediately for these patients. So generally in that pre authorization they say, okay, you can use these antibiotics for first 48 to 72 hours, till the time you haven't identified the organism, you have not identified the source of infection. By the time 48 72 hours reports are available, so then at that time you need a review by a senior consultant, who can then say, okay, this broad spectrum antibiotic can be continued, or it should be de-escalated from broad spectrum to narrow spectrum. So, or stop decisions may also be taken. So these are they work very well, this thing. And for this formulary restriction, you know, how do you decide if you go by the services department? In my experience, the restrictions by services is very effective. But how do you use it? What is the criteria for doing this? So for this optimization of antimicrobial use, aware classification of antibiotic has been given by WHO. They have divided all the antibiotics into three categories: excess, watch, and reserve. So, excess, as the name suggests, if you look at the amoxicillin, clavulanic acid, penicillin, cephalexin, first and second generation cephalosporins come in, doxycycline, gentamicin, nitrofurantoin, penicillins, cotrimoxazole. All these drugs have been put under the excess because these are very important basic antibiotics which are needed for treatment of infectious diseases. So these drugs should be available at all health facilities at all levels. So excess means that. Reserve, as the name suggests, this is for this is a kind of last resort antibiotic, that if you have nothing else available, these antibiotic, if the patient is not responding, these are the antibiotics that can help you, as a last resort. So of course we need to protect these reserve antibiotics. If we misuse these for non-serious infections, we will be losing out on this precious reserve antibiotics. So we'll have nothing for the treatment of the patient. Now in between is a watch category. It's a watch category. Now if you carefully look at this, what are the types of drugs that they are there in this? Is azithromycin, Cefixime, Cefodox, third generation cephalosporin. They are in the watch category. This fluoroquinolones come under this watch category. Meropenem, piperacillin, vancomycin, they all come under the watch category. Why watch? Because these patients, these drugs are used frequently in the inpatient department. So, and but they have a potential for development of AMR. Resistance develop potential is high with these drugs. So if we don't watch the trends, patterns of prescribing of watch group of drugs, we may lose out on these effective medicines. Most of the time these are effective, and that is how we are able to save. So the target here is that we should, if at all we have to use antibiotic, we choose from excess group. Okay, but on the contrary, during COVID times, we saw, even when the diagnosis of COVID was made, people use azithromycin, whereas doxycycline could have worked for this patient. And especially whenever you are in doubt, just in case you are prescribing, it is always advisable that you use a antibiotic from the excess group but not from the watch group. That is something, if we can, I think it is very easy to practice, and it will help in slowing down the development of resistance. Now, coming back to this formulary restrictions by OPD, IPD, emergency, and ICU, you can use this classification, aware classification, for doing so. You can say, okay, the oral medicines from the excess group will be made available in the outdoor department, OPD. These are the ones which will be used in the indoor department only. And of course, these, in fact, I say meropenem, piperacillin, vancomycin, these also should be used very sparingly, as a reserve drug only, because in India we don't have this many of these Vibarbactam and all that. They are not available, so we need to protect this. So use this also as a reserve drug only, and watch that people are adhering to this. Then we can another very effective way of reducing the antibiotic use is timeout. As I told you, the pre-authorization is for 48 to 72 hours to use the broad spectrum antibiotic. So, in private hospitals, they do this and they do it very effectively. They stop these broad spectrum antibiotic after 48 to 72 hours, unless the consultant reviews the patient and writes whether this broad spectrum antibiotic should be continued or not. So this helps saving the broad spectrum antibiotics to quite a extent. So before there are four things that are very important when it comes to antimicrobial prescribing. That indication has to be there. We need to be very clear, what are we trying to achieve with this antibiotic. Is it the bacterial infection that you want to treat, or is it the viral infection, self-limiting illness? Diarrhea is a self-limiting illness. The mainstay of treatment in diarrhea is rehydration, because deaths in diarrhea are mostly because of dehydration and not because of the septicemia occurring subsequent to this watery viral infection. So be careful about this. Then, if you grow something in the sample, urine or blood, be careful. We must distinguish between whether this is a contaminant or a colonizer, or is it a true pathogen that we have identified, and then accordingly you prescribe. Review is very important. Review, what happens, the most difficult thing that I'm not saying difficult, most neglected thing is that prescription decisions are taken, we prescribe, but we fail to review after 48 hours, 72 hours, whether it is working for the patient or not, whether the patient is improving or not. Meanwhile, you may get a diagnosis, oh, this was not a bacterial infection, it is a viral infection, or it is something else, and this is not the right drug. But since we are not reviewing this, we don't get to know, and we don't get to switch therapy to suit these patients. So review is very important. I think if you, after this session, and at least when you go back to your clinics, if you are able to do this review after second day, third day, what's happening to the pulse, temperature, respiratory rate, then you will know whether the patient is responding or not, and you can take swift actions as suitable for this. Then of course the stop decision is as important. Many times with antibiotics we have seen, if the patient stays in the hospital, initial stay was not expected to go beyond 5 days, 7 days, but something happens, some complications happen, or for some other reasons the stay may be prolonged, and the patient continues to get these antibiotics for the duration of stay in the hospital. So stop. If you write in the when you write a prescription for antimicrobial, one action plan should be there, that okay, we plan to give this antibiotic for 5 days, 7 days, 3 days, whatever is the condition of the, and in between, after 48 hours you will review. So nurses also know that this plan was only for 5 days, so they will not continue these antibiotics beyond 5 days unless you give specific directions to extend the treatment with antibiotic. So writing a plan, action plan, that you plan it for 3 days, 5 days, 10 days, so accordingly nurses also know. So unnecessarily prolongation of antimicrobial therapy can be stopped by just simply writing one line that you plan it to give it for such and such duration. So stop duration is important. Then whether you go for oral antibiotics or parenteral antibiotics. Unfortunately, the belief is that the parenteral antibiotics are stronger, and the sick patient need the parenteral antibiotic only. This was true when we did not have good oral antibiotics available. Now we have cefixime available. If cefixime is working, why do we need to give ceftriaxone for that? So earlier, this was because oral was not there. But unfortunately, this belief is still continuing, and patients are continued on IV. So this means patient stays in bed for longer time, more opportunities, for getting infections. So if possible, if oral agent, good oral agent, suitable for that patient is available, one should prescribe oral as far as possible. So always prefer oral than IM or IV. But I want to give a word of caution here. Oral antibiotics have a greatest potential for misuse. Cefixime is the one. I have seen patients getting cefixime in the outdoor department. I have seen cefixime being prescribed for normal delivery patient as a regular package after delivery. Normal delivery, no infection, nothing, no prolonged labor or other doubt about the infection, but as a package they get cefixime. So linezolid is another example. So we need to be really very careful about this oral antimicrobials. If at all you have to prescribe, remember that you should prescribe it from the excess group, not from the watch group. Okay, now coming to de-escalation, I've been using this term very often in my this de-escalation is, as I said, in emergency, if the patient has presented to you with a life-threatening infection, you have all rights to prescribe a broad spectrum drug like piperacillin, meropenem, or any one of these type. But after 48, because broader the spectrum, as I said, they will cause more damage also to the body. For example, as they kill both, they cannot differentiate between good bacteria and bad bacteria. So, but while treating the patient, we don't want to disturb the good bacteria. We want to target only the bad bacteria. But unfortunately, broad spectrum, as their name suggests, they cannot distinguish, and they will kill both good and bad. So that will be bad for our body if the good bacteria are killed. Clostridium difficile like infection happens, AMR happens, because of that. So we want that these broad spectrum antibiotics are given for the shortest duration necessary for the patient. Okay, so switching from broad to narrow spectrum is called de-escalation. From IV to oral is called de-escalation. Just because patient was serious, patient was not able to take it orally, uh, patient was having high fever, you could not give it orally. At that time, IV drugs were started, but as soon as the patient becomes stable, he is tolerating orally, an oral good option is available, one should try to shift from IV to oral as early as possible. Then you may start with a high dose loading dose in the emergency, try to lower down if the patient is stable. From combination to a single drug is also called a de-escalation. Sometimes because in emergency we don't know the source, we don't know the germ, so sometimes we don't know whether this is gram negative or positive. So we may start with the combination 2 or 3 antibiotic, but this again should not be continued beyond a period. We should try to switch from, as you have reports available, switch from combination to a mono antimicrobial therapy. So this is called de-escalation. I think this is one of very effective strategies, especially the switching from IV to oral is something that you can do it easily. Switching from combination to a single drug is another very important uh, intervention that you can do that will reduce the pressure on this. And sometimes then the stopping decisions, duration is also very important. Sometimes as the antibiotics may be continued, so this will increase the potential for development of AMR. So if required, these should be given for the shortest duration. I can give you the example of pneumonia. I've been in the development, STG development process for last 25 years. We started with 14 days treatment for pneumonia. Then subsequently it was brought down to 10 days, 5 to 7 days. Now it is 5 days. So 5 days of effective treatment with antibiotic can take care of community acquired pneumonia. So continuing this beyond till the time the X-ray, consolidation clears up, amounts to overuse of which is unnecessary. So the duration you can work, cystitis, uncomplicated cystitis, particularly in a woman. Now the treatment duration says 3 days is enough. So like that there are guidelines for duration. So if at all we had prescribed an antibiotic, we should try to optimize the duration. And especially if you have given an antibiotic which was just in case, should never be extended. That treatment should be stopped as early as possible. If you make the diagnosis and you know that this is viral, you should stop that. So stop decisions are also important. You can utilize serological markers for taking these stopping decisions. But these are, I want to, say this very upfront here, is that markers, these you have to follow the trends, बट डोंट चेज टू नॉर्मल कि वो नॉर्मल हो जाए, ऐसा नहीं सोचिए कि नॉर्मल हो जाएंगे तब स्टॉप करेंगे. यू हैव टू लुक एट द ट्रेंड, whether the trend is rising or trend is declining. So there are cutoff points. There are trends that you need to look at. You can do this PCT, procalcitonin. You can take CRP. This is a traditional one. Long time it has been available. It can still, although it is a slower to rise, slower to fall down, but its trajectory, the pattern can give you useful information. A white cell count, ANC, although are non-specific, but still can tell you whether what is the clinical course being there. ESR, ferritin. You cannot use it for stop decisions, but this can tell you the trends. So use trends with clinical stability, and don't use a single value. It is always the trend that will help you take those decisions. And it is important, once the source is controlled, culture results are available, then usually if you have targeted therapy, you will find a decline. So consider other factors. So my caution to you is that these biomarkers support decisions, but they don't replace clinical assessment. So whatever you do look at the patients as well. So we all know that the choice of antibiotic agent should be based on the etiological agent, patient related factors, antibiotic related factors. And when we use empirical antibiotics, empirical means when we don't know, we are in the dark, we don't know what is the organism, we use a broad spectrum antibiotic for a life threatening infection or at risk patient at risk of serious morbidity. We call this as empirical therapy. Now, as I told you, broad spectrum have their own problems, so we should try to minimize. And just to for my friends who are working at the CHO level or nurses, broad spectrum means they work on wide class of pathogens. They work on, as the if you can look at these baskets, this will tell you, broad spectrum work on gram positive, negative anaerobes, whereas monospectrum, narrow spectrum, they act on single type of bacteria. There are bactericidal drugs which kill the bacteria, bacteristatic. They just stop the multiplication of these bacteria. So we need to be very careful, which one are these. So you don't combine bacteriostatic antibiotic with bactericidal, because then it will make the bactericidal antibiotic also as a bacteristatic. So in treating the infections, there are 3-4 things that we need to keep in mind. Dosage regimen. We need to achieve a certain concentration in the serum for it to reach the infection site. It could be brain, it could be lung, it could be bone, it could be GIT, it could be liver. So concentration at infectious site has to be achieved, and then only it will have a biological effect. Biological effect here means effect on the germs, pathogens. So for this to be there, you have to reach the MIC, minimum inhibitory concentration of these antibiotics in the blood. So first three are pharmacokinetics, where what body does to the drug, what happens to the absorption, what happens to their distribution, metabolism, and excretion. So all this is our pharmacokinetics. And the biological effect here, ideally speaking, pharmacodynamics is the effect of the drug on the body. So, but here we are not talking about the effect of the drug on the body. We are talking about dynamics effect on the germs. So that is why we are calling it as a biological effect. So there are few things, we need to take care of these, because if we want, this will help us achieve the right exposures, minimize toxicity, costs, reduce selection, and you need to address the various patient specific ICU, obesity, dialysis, pediatrics, which antibiotics to be used in pregnancy, like that. So I think this is very specific here. But you need to, when you are prescribing, just take care of patient characteristics, whether it is a child, pregnant, obese, whatever, site of infection, the pharmacological properties of the antimicrobial agents, susceptibility status, and interactions. And of course, if you look at, for this antimicrobial stewardship program, another thing that has been seen is that we follow the infectious syndrome approach here, because patients don't come with a diagnosis, they come with this host of symptoms, presenting symptoms, and we know the likely cause of those infections. So that helps us selecting the infection, the treatment, appropriate antibiotic for these patients. But then how do you do this? You need to look at the for example, in a uncomplicated cystitis, we need to choose the urine concentrating agent, because we need to take care of the if the drug is not concentrating in the urine, it will not be effective. Similarly, for pyelonephritis, we don't need, here in this case, nitrofurantoin is the most effective. It reaches the high urine concentration, so that is why it is used as a first line agent for uncomplicated cystitis. And moxifloxacin is not used because it does not reach the good excretion in the urine. So ceftriaxone is also unnecessary here, because one, it is broad spectrum, then it has to be given IV. Doxycycline is ineffective for common, this depends on the susceptibility pattern. But when it comes to pyelonephritis, that means upper urinary system infection, then this urine only drugs are not enough here. Then you need a systemic drug which can reach a good concentration in the renal parenchyma for penetration. So like that, you take these decisions. Similarly, which drug should you give in meningitis, which drug should you give in prosthetic, these decisions are based on, today I don't have much time to go through all these things, but site specific infections can also decide the choice of antibiotic. For example, linezolid is preferred over vancomycin, but you don't use deptomycin in pneumonia. Meningitis, high dose ceftriaxone is used because it cannot penetrate the meninges. But then you have to be very careful about the seizures, the seizure potential of high dose of ceftriaxone. Sepsis, you start with broad spectrum. Prefer antibiotics with high volume of distribution. One more thing, from the AMSP angle, is that you should try, if you have made these diagnoses like sepsis, pneumonia, one should try and start these antibiotics within 1 hour of the diagnosis, and loading dose should be given if you are suspecting sepsis. But one more thing that from stewardship angle is that when you start these antibiotics, one must take the sample for microbiological testing before giving the first dose of antibiotic. Now, because even single dose of antibiotic can render your microbiology analysis, diagnosis, you will find no growth was there. Sterile sample is reported. So this happens because usually we forget to take these samples, and patient has already received the antibiotic. But once this antibiotic is given, you will not grow anything. So be careful about it. You have to start early with antibiotics in sepsis, but remember to draw samples before giving the first. So here comes the role of nurses, because they are the ones who are going to administer this antibiotic to this patient, so they can assure that the sample is taken before the first dose. Okay. I think there are, drugs, you can use this, aminoglycosides is a good choice for sepsis, but it does not penetrate into soft tissue, bone, lungs, CSF. So don't give aminoglycosides for these infections, only for sepsis. Whereas beta lactam have a good penetration into soft tissue, bone, lung. So, but beta lactams cannot enter into the abscess, so don't give beta lactams for abscess. So like that, you can choose the drugs. I think then don't forget one thing. We most of the time when we prescribe antibiotic, we think that the antibiotics are harmless. They are not harmless. Resistance, as I told you, is the problem. Super infections can happen. C difficile infection, especially when you are using broad spectrum antibiotics. Fluoroquinolones, vancomycin, they are particularly associated with the C. difficile associated diarrhea. So, and it has cost also. It increases the cost of therapy, duration of stay in the hospital. You use higher end antibiotics, which are costlier and which have a higher toxicity. Hypersensitivity reactions can happen, direct toxicity can happen. So, and dose related toxicity require dose adjustment. So these are all the complications of antibiotics. Don't think that they are harmless. 1 in 5 patients will have some complication due to antimicrobial therapy. The other day I was reading those mothers who receive antibiotics during delivery. These neonates have more lung problems because then the flora change and all that. So be careful, it has impact on the neonate as well. And consider the side effect profile before choosing. And you can use this infectious clinical syndrome approach for this. I think one very specific post viral cough does not need antibiotic. Avoid antibiotic, it will respond to supportive symptomatic care. Home remedies will work, but no antibiotic. Treat the patient, not the duration of the curve. Similarly, acute bronchitis, this is expected to last for 3 weeks. Symptomatic treatment is needed, no antibiotics for cough. Yes, we are worried about the sore throat. You should know the indications when can you use this. So clinical clues are there which using which you can distinguish between viral and the streptococcal infections. So usually these are the symptoms. And if you have uh, two membranes, mucous membranes are affected, patient is having running nose and running eyes, tears are coming down, diarrhea is there, think in terms of viral infections. Bacterial infections don't spread so fast, and you can use this centaur score for that. For each this thing there is a criteria points for that. If 0 or 1 score is there, there is no point in using antibiotic. I can't go into the details, but somehow acute exacerbations of COPD, again they don't need antibiotic. Only needed when there is more dyspnea, increased sputum volume, or new purulence is there. Otherwise people are chasing वो green color का sputum है कि yellow color का sputum है, white. No, there is no need for even for this. Look at the control of bronchodilation. That is the key, not the antibiotics. I think I'll uh, Dr. Romit is already there. LSCS, I already told you, routine use of this. Yeah, one more thing that I would like to say here, because we have people from all the places here, that this thing. LSCS, most of us are delivering mother and child services. Again, antibiotics are misused post operatively. You just need one single dose of antibiotic here. You don't need, you don't need post operative antibiotics. One single dose, 60 minutes to 120 minutes before the incision is given, is the most important thing that you can do. Other more important things, infections, wound infections, surgical site infections happen because of poor skin preparation, because of poor glycemic control. Diabetic patients, if the sugar is not controlled, he will have more infection. If there is patient's body temperature drops during surgery, or if the wound handling is not proper. Many times I've seen clinicians, when they are on round, they examine the wound dressing of the patient. Of course, there are sharing of beds, and without washing hands, they examine the wound of the other patient. So that's how we are transmitting these. So just don't depend on the antibiotic. Look at these aspects as well, how the wound is being handled. If you are not following sterile practices, this, and sometimes even these antibiotics are used as long as the drain is in situ. जब तक ड्रेन लगा है, लंग में वो किया है, थोरेकॉटमी किया है, जब तक ड्रेन में लगा है तब तक एंटीबायोटिक. अगेन, नो, नॉट नीडेड. Only one dose of antibiotic is needed at the time of insertion of this tube. Then you don't need it. Then people are using for a normal delivery episiotomy, because they are giving episiotomy. That is why they are using. No, again, if it is a clean mediolateral episiotomy, patient is afebrile, wound is healthy, you don't need antibiotic. There are few indications when you can give, but no routine postpartum antibiotics. If it is meconium stain, liquor, is there, contamination is there, then only you can use. Diabetic patient, you are really concerned about it, then it is. Another area is skin and soft tissue infections. Again, you have purulent infections, non-purulent infections. You have to look at it whether it is localized or widespread. Then, of course, if it is non-purulent like cellulitis, erysipelas, you need antibiotics. But you also must recognize the danger signs here, red flag signs here, which should prompt immediate action and to save the patient. Now coming to purulent one, these are very common. Abscesses, furuncle, carbuncle. Again, antibiotics are misused here. Here the source control is very important. One must do the incision and drainage here. I think I'll stop this here. Just go down. Duration I already told you. Ultimately, okay, my take home message is, must think beyond, before you prescribe. Only antibiotics work against the bacterial infections. Not all fevers are due to infection. This rise in fever, body temperature could be because of other reasons, and not all infections are due to bacteria. So don't try to treat viral infections with antibiotics. And there is no evidence that antibiotics will prevent secondary bacterial infection. कि अभी नहीं देंगे, बाद में देना पड़ेगा. That's not the right approach, because they don't prevent secondary infections. When it develops, you can always give, but just don't give them prophylactically. Prophylactic use is only for the surgeries, not here. And then try to see if you can manage the infection with other means. If there is a wound, you are not debriding. Cellulitis is there, you are not debriding. Abscess is there, if you are not giving incision and drainage, it is not going to help. Catheter is the source, if you are not removing the catheter, this is not going to help. So please remember this. Do this. And of course, you are in the position where you have to take these decisions, so you have to do a balancing act. You have individual patient in front of you, and you have communities where this AMR becomes a problem. So you have to really be taking care of this. Our advice would be just to follow the standard treatment guidelines that will tell you the right appropriate indication, appropriate choice of antibiotic, and duration, route, etc. So follow guidelines, that is going to help you. I think we have to be antibiotic smart and get well soon without antibiotics. That's it. Thank you. This was a very long this thing. I have tried to give you the snapshot of it, and I think Romit is already there, is waiting. uh, I think this session is also very, very important because very often we are not able to recognize the danger signs, or which child is deteriorating, or which needs immediate action. So I think this second part is also very, very important. Romit is there?
Thank you, ma'am. Am I audible?
Yes.
Okay. Thank you, guys. So I shall try because I think this is also an important section. And as ma'am was rightly saying, that one has to understand that, just bear with me. This is, yeah. Okay. So communicable diseases is the most, and infectious diseases is essentially one of the most important things which come to us in the outpatient department, and we are often perplexed depending upon what we have and how to treat it. And especially when our decisions deal with life and death, we are on the side of doing rather than watchful expectancy. Herein the concept of let's give some antibiotic comes into play. But as ma'am has told, it is the restraint which is equally important than just giving it. So one important aspect of this is the administration of is communicable diseases. I'm just trying to see, there is bear with me. Is this also visible? This right now it's better.
Yes, it
So
is.
yeah, okay. So we'll be discussing communicable diseases in certain heads. Let's start with understanding what exactly is contagious, and just a quick primer on that, and why is it actually important for us to discuss this aspect. So as you can see that up till now, overall in the world, 37 children who die out of 1,000 still do not cross 5 years of age. And this number is still 27, which means around 0.05% of kids who die, who are born, will not see their fifth birthday. And unfortunately, communicable diseases are a very important aspect which contribute to it. So what exactly are they? They are diseases which can be because of any etiological agents, which can be spread from one person to another, and they can be spread through any means, be it contaminated surfaces, fluids, blood products, airs, fomites, through any means. So it is transmissible. What it understands is that there exists something called as a transmission cycle, wherein a microbe, which might be a bacteria, a protozoan, or which might be maybe anything, it stays somewhere in the environment, which is what is the reservoir. This might be people, this might be equipment, this might be you have just sneezed onto and just you are traveling in a metro and you are grasping onto the railing. So that itself, it will just stay on the environment. From there it enters into another person through either by touching that fomite, or if the person who is infected coughs onto somebody else and the other person is not wearing a mask, it gets transmitted depending upon what is the mode, either through air, through touch, through some insect, especially when it is vector borne. It enters into another human being. that human being, if the immunity is less, it will start multiplying before being shed again into the environment. This transmission cycle, it it can be dependent upon how the organism is spread. It can be by contact transmission, droplet transmission, airborne, vehicle, and vector borne. So depending upon how it is, and we get a lot of patients to us in our OPDs. We have examples like dengue fever, which are vector-borne, droplet-borne infections, influenza. I'm sure all of you are seeing so many cough, cold, coryza in your OPDs right now. And obviously, there can be some skin germ contact precautions like monkeypox, chickenpox, all these illnesses. I'm going to emphasize more on the pediatric aspect because we are seeing a lot of pediatric upsurge in viral infections nowadays. So I'm going to be emphasizing more on that aspect. This is to show that across the world, you can see acute LRTI, India is still a contributor of majority of deaths because of it. Similarly, diarrheal diseases, India contributes to a lot of diarrheal disease related deaths under 5. Why I'm emphasizing and showing the slide is these are preventable deaths. These are deaths with adequate treatment, with adequate identification, with breakage of transmission cycle, like making good hygiene, like ensuring adequate drugs are given, like simple measures like giving ORS, those kind of things, the death can be completely preventable and avoided. So we have to understand what is being caused, intervene, and if intervened at the right way in the right time, it will decrease the mortality burden across the country. Why it is specifically important now is that unlike earlier times when there used to be disease like plague, in the 1600s, the whole towns used to get locked, that this town has plague, nobody will exit or enter this town, people will die, and then only the whole town will be burnt. Now after 500 years hence, we obviously are in a different era altogether. There is a huge connectivity. There might be an infection which starts at one part of the globe, it spreads into India, and it spreads across the globe. So we have to understand we are not immune irrespective of where the infection comes in. And as we can see, most of the pandemics which Madam was talking about, there have been mostly viral borne. And the reason they are viral borne is because it is extremely communicable. It is easily spread from one person to another. So now that we understand that this is a very important topic, communicable diseases is what leads to a lot of mortality and mortality burden. We have to understand how do we approach. Now imagine if there's a patient who comes to you with fever. The mother is obviously very anxious. My kid has high grade fever. He's not sleeping in the night. He's not eating. So does it mean, as Madam had said, we have to start ceftriaxone, admit him? Do we have to start cefixime, or if not, at least azithromycin? So we have to understand, and if not, why not order tests? So we have to understand that the whole aspect is the major. So one of my teachers, Sethi sir and Dr. Amji sir, they used to tell that any patient who comes to you, if the whole diagnosis 100%, 50% you can get by a good history, at least 30% or at least 35% more you'll get by a good examination. That is 85% of the time you'll get a good answer by doing the what it is. Then then another 10% you'll do by simple blood test, be it CBC, CRP, not advanced tests, just simple blood test. And it is only in the remaining 5% you need advanced test. So just a good history examination often gives you all the clues. And in kids specifically, fortunately or unfortunately, they give a lot of symptoms and signs, in the sense, though they will not tell you what is wrong, but if a good pediatrician, a good doctor, by examining lymph nodes, rash, muscle aches, exhaustion, difference in level of activity, by doing a systematic examination, you can get to what organism you are dealing with. For example, a patient comes to you with high grade fever. Just if you forget to look at the throat, you will obviously miss that this patient has actually having a tonsilopharyngitis, and this patient will keep on coughing and spreading the infection as a communicable disease. Similarly, if you don't examine the nose, you will miss out on important signs. Another important aspect of fever with rash, which is another important communicable disease, is that there are a lot of exanthems and enanthems. Exanthem is a rash that comes on the skin. Enanthem is a rash which is in the mucous membrane, which is inside the mouth. So this, if the audience can guess, is chickenpox. Again, if the parents are apprehensive, it is very important to examine they put up the clothes, examine the rash, see the distribution. Why it is important is because knowing what organism and knowing what disease you are dealing with will help identify whether it is viral or bacterial, will help you implement the right control measures. Like a patient of chickenpox, you will ask to not go to school. Similarly, if you don't examine the mouth, you will again miss a lot of other diseases. See, this is herpangina. Hand, foot, mouth disease epidemic. We had seen a lot of patients recently. So, and so just taking a good history, what day the fever started, on what day of illness the rash started, where did the rash start? Did it start from the abdomen? Did it start on the extremities? Is it itchy, not itchy? Is there some difficulty in swallowing? The normal questions we ask: how the fever is, the grade, pattern, chills, rigors, is it got any exacerbating signs? Is it getting relieved in paracetamol? How long does it stay relieved? Is there a rash? What is the distribution of rash? And just, is there sneezing? Again, as madam had rightly pointed out, the color of the sputum and that is not important, because that color is actually coming from the pus cells. It is not the organism which is causing it. It is your body's immunity which is rendering the color to the sputum or the nasal discharge. So that itself doesn't imply the sickness level, but the presence or absence of the same can imply as to what the etiology of the disease is. Similarly, just looking at the child can give you an idea as to what kind of a disease process you're dealing with, and whether it will be an understanding that it is a viral illness will help you thereby um, intervene in the transmission cycle, treat the patient while stopping and instituting adequate isolation precaution. Three important disease I just want to discuss before going on to the general disease, just because in this particular season I'm seeing a lot of them, is that measles, know the three C's: cough, coryza, conjunctivitis, and know the characteristic rash, which occurs after 2 to 4 days of uh, fever. And always learn to examine the mouth. And when you're doing it, always remember to wear a mask, because you don't want to take the infection home. And you can see the characteristic rash on the body, and you're having measles. Similarly, chickenpox, you can get a history of contact, and you know that after 2.5 weeks of exposure, you will have a rash. And this is an example of a dewdrop on a rose petal characteristic appearance, which will be there, and this vessel will thereafter become umbilicated and form a crust on the surface. And this is how it will look like ultimately. Mumps, highly infectious. And if it is, what is scary in this is, a lot of patients who might be harboring it may not be. So if one child comes into the class with this infection, 1/3 of the class may have the disease without showing any manifestations. This is scary because they will keep on transmitting, and they are not, and which is what the the disease will just spread like a wildfire and causing an outbreak. And the treatment in all these diseases is essentially symptomatic. As Mehmet said, no antibiotic. It is not a sign of ceftriaxone or azithromycin deficiency. Just treat, give analgesics, and treat accordingly. So there was one important topic that was given to me is the danger signs. So first important to understand is communicable disease includes everything, be it foodborne. They are being communicated by fecal-oral route. There might be skin infections which might be communicated like chickenpox, pediculosis, staph infections. There might be respiratory illnesses like COVID, or might be skin infection like monkeypox. The symptoms and management of the same is essentially depending upon how sick the child is at admission. So imagine you are in a very busy OPD. There are 100 patients waiting. One father whose child is absolutely normal, just he's having some kind of a small rash on the body, but he's otherwise all right. Some coryza, and that kid is, and the father is making a lot of noise that treat my child. I've come first in the line. On the other hand, the quiet mother is sitting at the back of the line with the child wrapped in her arms, waiting her turn, and the child who was having a chicken pox, now having a staph pneumonia, is gasping. So it is your responsibility as a doctor to understand it is not first come, first serve. It is the severity of illness which deals with it. Because that lady, by the time she comes to you, that patient may be dead. This father, even if he waits for the next 6 hours, the kid will be all right. Even if he goes back, doesn't matter. But that kid will die before he comes to you in that line of 100. So what is important to understand is that triaging identification of sick patients is a duty wherever you have them, be it OPD, be it emergency, be it ward. Sick patient, depending upon the sickness, comes first. So often we see, senior professors come into the emergency room, they look, but just look through the whole thing, they and say this, that patient at the end, that patient is very sick, I need to see that patient first. How do they get that? Do they have a sixth sense? What they're doing is just by looking at them, they are getting a mental picture based on their experience. Obviously, they have not auscultated by looking from afar. What they have done is looked at the appearance, color, and breathing from a distance. So you don't have to be a senior professor to do it. You can just follow systematically how to approach a danger sign, and you'll be at the same level at examination and identifying them. So the first thing when a patient comes to you, you evaluate by the pediatric assessment triangle. See, irrespective of what the cause is, it might be a patient of chickenpox, it might be a patient of COVID. The first thing you see is your ABC. You see if the patient is conscious, breathing, and the patient has good color. This is to identify if the patient has a life-threatening problem. If the patient has it, come to the front of the queue and patient needs to be intervened. If the patient is in arrest, obviously CPR starts. If the patient is gasping, you need to intubate. If the patient needs, a patient has low SpO2 or is looking blue, you start oxygen. So before you do anything else, this patient needs intervention. So evaluate, identify, intervene. You evaluated the CBC, consciousness, breathing, color. You intervened by doing the right management, and you identified that this was a life-threatening problem. So that is how you start, by just looking initial impression. After that, now you have stabilized them a little more, you go to the next part. You, after you've completed the initial assessment, at any time during this, you have the patient who is in arrest, you stop everything and you start CPR. Then after this, you go on to the primary assessment and you try to identify through the ABCDE, you try to identify whether this life-threatening situation is because of the respiratory, circulatory, or neurological. For example, you can have a patient who's having chickenpox with staph pneumonia with respiratory distress. You can have a child who is having bronchiolitis with respiratory failure. So depending upon how the child, how the work of breathing is, you will be able to categorize and whether the patient is having just increased work of breathing or increased work of breathing with alteration of sensorium and going towards failure. You need to make intervention accordingly. Similarly, whether the patient has a hemodynamic compromise, by looking at the pulse, heart rate, blood pressure, capillary refill time, end organ signs like urine output, you can identify whether this patient is in shock. And if in shock, where the BP is maintained, that is a compensatory shock, or if not, hypertensive shock. In both the cases, you need to intervene by giving fluid boluses and starting appropriate inotrope or vasopressors as needed. Neurologically, again, often because of cardiorespiratory compromise, the patient has lethargy and often may become, to the extent it might may become unconscious. The cause can be primary neurological involvement. For example, the viral infection was started in the lungs because of any virus, be it adeno, intro, be it COVID, it has gone to the brain, or it might be secondary because of the lung infection, it leads to hypoxia, and the hypoxia is what is impacting the brain. Either way, the intervention will be that the patient, whether the GCS has gone down, will need an airway and supportive measures if intracranial pressure is high. So what we have understood up till now is that the intervention remains the same irrespective of what the etiology is, because the interventions are dependent upon the physiological state of the child. Then once you have stabilized the child, now you need to go and identify what the heck was wrong with him. How we go around with this is again a systematic approach. If we jump any of these things, we'll end up missing it. What madam has pointed out was that identifying the cause and treating the cause is more important than giving a broad spectrum everything for everybody. You can't start a Miro, Banco, Flucon for every patient with fever, cough, fever who comes to you. Otherwise, after some time, it'll stop working. So what you need to do is identify, look how the patient is the airway maintainable, not maintainable, look at the breathing, see whether how is the respiratory pattern, whether the chest is expanding, how examine. Remember your basics, what I had said in the beginning. A good history examination give you 85% of the time where you want to go. Remember to do your inspection, palpation, percussion. Remember to, in small kids, lift the shirt. It's often what happens is in the winters when they're wearing such woolly clothes, you do not see the respiratory distress. So, and when you lift up the clothes, you see that there's a lot of retractions there. So remember to expose, examine, inspect, palpate, percuss, obviously with parental permissions. And remember, SpO2 is also in your armamentarium as a vital sign. So not just heart rate, respiratory rate, blood pressure. Now SpO2 is also there, which you need to see. Circulation basics. Again, don't go into advanced stuff like you need cardiometry, ultrasounds, for everything. Basics is what wins the game. Looking at the heart rate, how the rhythm is, pulses, capillary refill, skin color, temperature. If you have got a good monitor and a BP cuff, yes, BP cuff will help you identify and titrate your management. Looking at things like liver, looking at hepatomegaly. So make your college teachers proud. Ensure that you hold on the legacy for good inspection, palpation, percussion wherever you go. Then again, classify your neurological status. Why it is important is you might be on a shift duty. You might say the patient is drowsy. But if you don't categorize that the GCS was this much, now you have intervened, now the GCS is improved, the other person will not be able to monitor. So it's very important to categorize where you are. And similarly, temperature and whether there's a rash. Secondary assessment, diagnostic assessments are so secondary assessment is obviously important because that helps you identify. So you have a patient who had come with lethargy, respiratory distress, and had come with a lot of work of breathing, where you examined and they found crepitations, and you admitted, started on oxygen, you did your primary assessment, you started on the patient has improved, he was in shock, you started to give some fluid boluses. Now you have stabilized him. Now you ask some more history. As you probe, what are the signs, when was the last allergy, last meal, what was any past history, you will then asking further questions. You might get a history like, Dr. Saab, this patient had a trauma on the leg 3 days back, कोई fast उब गया था पाँव में और उसके बाद शुरू हुआ. या फिर the doctor साहब in his class everybody has cough cold coryza and he has been coughing for the last 4 days. Dr. Saab, there was a rash 1.5 weeks back and it has desquamated to have this brown color thing, measles, post measles rash, and now he's having high grade fever which alerts you to a staph infection. So understand. And similarly you might say, Dr. Saab, ये तो ना अपने बिल्ली और कुत्ते के साथ ही खेलता रहता है, या फिर इसके आसपास बहुत सारी मक्खियां भिनभिनाती रहती हैं, ये अपने खाने, ये तो गंदगी में ही रहता है. सो अंडरस्टैंडिंग दैट, या फिर ये अभी डॉक्टर साहब मेला गया था अभी दशहरे पे और इसने बाहर बहुत सारे गोलगप्पे खाए थे. So knowing the history, you'll be able to understand whether you're dealing with a foodborne communicable disease, airborne disease, whether you're dealing with a contact precaution, and obviously you can tailor your antibiotic decision or whether antibiotics is required or not by taking that. Diagnostic tests will again supplement and complement your decision, not replace them. Okay, so we had discussed about now identifying these important vital signs. Now they are important because on the base of these emergency signs, you know which patient will come in the front of the queue. And so what is your job when you are identifying, you've got a communicable disease patient who is having a potential of these signs and you have a long queue of them. And you are a medical officer and you have got a CMO who is there or a pediatrician who is there along with you. What you do is you look for these ABC, you see the primary assessment, you see and identify any emergency signs. Suppose you feel this something not right, he's breathing funny, his respiratory rate is a lot, he's looking blue. All the senior, he will do the same thing, he will look for priority signs and then he will try the management. So what are these things which we are looking for? what we are looking for. So what happens is that a lot of studies were done, and all these parameters were actually put in ChatGPT, DeepSeek, and it came to the same conclusion which our seniors and teachers have been telling us for the last 60 years. Respiratory rate, heart rate, SpO2, consciousness, these are the ones which predict mortality. A smaller the kid, lower the weight, all these things are important. So understanding that, we have to understand now there should be a simpler reason. I can't go whacking my head every time and understanding. So there should be some kind of a tool which will help me identify these sick patients. Yes, a lot of studies have been there. WHO has actually got a tool called emergency triage and treatment, which will help you identify any such disease which comes to you. So what you do, again, irrespective of whether it is communicable, whether it is viral, whether it is foodborne, whether it is droplet borne, airborne, your intervention digestion will be almost common. You look for the airway, you see where there's obstructive breathing, cyanosis, respiratory distress. So A, B, C, D. So airway, breathing, circulation, comma, conversion, and dehydration. These things will help you identify and triage. So I am hoping all the medical officers and fellows in the audience have gone through this book, Emergency Triage and Treatment. This is a manual which is there and easily accessible. Just Google it and you'll be able to get it. Very simple and a short manual, and almost a lot of people across the globe are following this. So what it does is it identifies patients into emergency cases, priority cases, and non-urgent cases. As we had said, the emergency signs are based on the A, B, C, D, and there's some priority signs, mean that if the patient has this, there is a good chance even if he has a minor illness, he might tip off and become sicker. For example, a small kid who comes to you with not eating or not drinking milk for 6 hours, as compared to a child who is 8 years old who has not drunk for 6 hours. A 1.5 kilo 3-day child who has not drunk is more likely to be hypoglycemic and even arrest. So temperature, patient who is very hot or very cold, both are to be there. Any trauma, especially fall from heights, road traffic accidents, any surgical condition in the form of, so remember, we are going to get in the winter seasons a lot of diarrheas, and there are a lot of rotavirus diarrheas. So often they have interceptions which might be have just have abdominal distension. So learn to identify that this something not right with the abdomen, and then obviously involve the surgical college into it. If the child is looking pale, so learn to examine their hands and the tongue and see whether there is a central palmar pallor or not. Poisoning, especially if the mother gives a history that Dr. Saab इसने अपने दादा की गोलियां खा ली हैं. She might not tell what exactly it is, but then you may have to infer or ask the दादाजी आप कौन सी गोलियां खाते. Pain, especially remember the signs of inflammation, rubor, color, dolor, fungiolizia. If the child is not moving his leg, the child, a 2-year-old child will not feign injury. If he's not moving his leg, something is not wrong. There might be some kind of a viral infection, myalgias, there might be a fracture, there might be a staphylococcal infection, you don't know. So always learn to examine the how rubor, color, dolor, and fungiolizia is spread throughout the body. Child is irritable, not accepting feeds. This is a red flag irrespective. Malnutrition. Any child who is not have adequate weight, even a small infection can lead to a bigger one. Edema. This we are pointing out whether this nephrotic or this kwashiorkor. This obviously is a red flag. And burns, because any of these things. So this is this mnemonic is 3 TPR MOB. So this will help you identify the priority signs. So understand, going back again. So what we did was we identified that the patient assessed the emergency signs, airway, breathing, circulation, coma, convulsion, and dehydration. We identified the priority signs, and then we saw these patients are the sickest, and we started treatment. Whether it be a staff, a communication because of droplet, communication because of a pneumonia, because of airborne, the management will be the same. Going on, a lot of you may have done IMNCI. I'm hoping so. So again, the principle and approach is similar, where you find which is similar to the ETAT approach, where you can see the ABCD is there, and as you can see, it is almost the same as what we were talking about in ETAT. So FMNCI is an extrapolation and adaptation from there, and as you can see that you can classify the patients as per the sickness level. What often many hospitals and many centers are doing, if not ETAT, they are using something called as a pediatric assessment triangle, because the doctors are very smart and they have undergone a BLS or ALS training. So what they do is they identify on the basis of the appearance, breathing and circulation at the beginning, and on the basis of that they classify distress, failure, shock, and you treat accordingly. This is an example of the triage form at the beginning. So irrespective of the cause, we get some degree of where the patient is and we start the treatment immediately. Remember, your results, your x-rays may take 8 hours, 6 hours to come, but your treatment, like starting oxygen, starting a fluid bolus, checking a glucose and giving a dextrose, starting oxygen, checking the SpO2, any arrhythmia, just detecting electrolytes, all those things can start much earlier, even before the reports come in. Going on, and as you can see, these are very helpful in identifying the sick patients and they'll help you admitting it. Going on, so who can triage, who can assess the vital signs? Does it need only the senior most professor to do it? Anybody can do it. You can see this, that what you can see through this is whether it is a nurse, ED physician, they have a senior nurse and a senior doctor with their experience, they can have a similar degree of identification. A junior doctor with uh, training, with adequate training, he can identify the danger sign, emergency signs in the emergency as much as a senior professor would. So what is required is good training, open eyes, inspection, palpation, percussion, and a systematic approach. How long does it take? Do I need to spend 1 hour on every child? No. To identify a sick child does not take more than 15 to 20 seconds. It's just like a, just couple of eye blinks and you will be able to identify what the sick patient is. So what we have gone up till now is we have identified what exactly is a communicable disease. We have talked about certain specific types. We have talked about how to approach it. We have talked about some specific communicable diseases in the context of pediatric ER. We have talked about how will you identify the sick children in a busy OPD ER of communicable diseases and on the base of their vital signs, how you can use some triaging tools to help you identify, and you don't have to just wing it. Now we go on to, you've identified it, now you are very much with the child. How do you control the infection? So what you have to understand is there are some standard precautions which need to be maintained for all kids who come to you, which include, so you are in a busy OPD, you should always be wearing certain precautions. So if you're handling secretions, always wear gloves. If you are just, you should always have a hand rub with you. If you're handling, if there is a spill around you, always remember to have just the adequate staff with the 3 bucket technique to clean it. And again, if you are handling a lot of infectious patients like chickenpox, wear gloves before you do it. Learn to have a mask. If not an N95, at least a normal face mask. Always wear it and remember how to wear it, and always remember that you need to how to take it out and how to wear it. So few things you have to understand is there are 5 things we discussed: fecal-oral route, airborne precaution, droplet precautions. So modes of transmission, there are adequate precautions which help us curtail that infection. One is contact precautions. This is where the person gets in direct contact with the infection. What this needs is using non-sterile gloves, hand washing and hand sepsis, and ensuring, and these all patients of bronchiolitis, conjunctivitis, loose stools, diphtheria, HSV, all these patients, RSV, scabies, pediculosis, all these require contact isolation. So that means when you touch such a patient, learn to wash your hands before you touch the next patient. Otherwise, you'll end up spreading it. Or if not anything else, you'll end up taking this infection home. So what is important is it is up to you as the MO, as a doctor, to stop that infection chain there by breaking the transmission cycle. Going on to droplet precautions, slightly more transmissible. How it does is any droplet more than 5 microgram. This is when I'm talking to you in close proximity. You are sneezing in the metro. You're talking. All those things will spread it. Or you can curtail it is wear a mask, Ensure if the patient is having droplet infection or airborne precaution, don't take him in the middle of a busy OPD for an X-ray, for a procedure, or if he requires, then choose a path such that the way is as clear as possible. Obviously, the patient severity, if it needs an X-ray, you have to take him. There's no option about it. But you can make the kid wear a mask. You can make, you can try to identify a better route. Again, small measures you can take. But obviously, if the patient needs an intervention that is life-saving or important, you'll have to do it. Going on, things like mumps, pertussis, adeno, mycoplasma, your seasonal or rather perennial rhinovirus, all these things are there. Then something more scary is airborne, because these are droplets which are 5 microgram or less. This spreads longer, this stays longer. So for this, you need a better mask like N95. This was our um, COVID, which had caused a high mortality rate. And again, you have to treat accordingly. A lot of patients, these things again are transmitted not just by airborne or droplet, they can be transmitted by contact precautions also. Things like influenza, all those things can be transmitted because when there is by fomites as well. So remember, identify how the transmission is happening and use the appropriate means to break the transmission cycle. Another thing in your armamentarium is immunization. Be it IEP protocol or be it the national immunization protocol, use what is recommended. But remember, building a herd immunity is often how you will end up protecting the population at large. So you have to be very careful. And remember, in your center, when you are administering vaccines, know where you keep what and whether you are monitoring them or not. So the final thing I will be trying to tell you is understand the difference between hand wash and hand rub. Hand rub, what often happens is people think हल्का सा हाथ धो लिया, बस हाथ मेरा साफ हो गया. You are fooling yourselves. हल्का सा साबुन लगाना, हल्का सा वो करना, there's nothing called हल्का सा. Either you do it well or you don't do it at all, because if you do not use the steps of hand hygiene, you don't use the movements of hand hygiene, you don't use the right thing, you are taking the infection on you and through you spreading it to your loved ones when you go home. Your small kid will be coming to, in your lap, you are taking the infection home. So remember, your precautions are helping not just you, but your loved ones. Also, they will help not spread the infection to the next patient, but it is immediately extrapolable to you as a human being. So remember, having this, that you are having, you need to have appropriate rub. I don't know whether you can hear me. Have a look. Are you able to hear the voiceover in the videos?
No, sir.
You are not able to hear the voice in the video?
No, sir. Just the video, no audio in the video.
Okay, I will see if I can share it. Bear with me. Let me see if I can share the audio. I'll be saying it aloud. If you can't hear it, I will try to just say what they are saying. So what is showing is wet hands with water. Just read the labels underneath. Apply enough soap to cover all the surfaces. Rub hands palm to palm. Right palm over the left dorsum with interlaced fingers and vice versa. Palm to palm with fingers interlocking. So ensure you clean your thumbs by rotational movements, rotational rubbing, and hand washing. So after that, see how he's washing it. He's and at the end dry, and don't touch the surface again. So remember, this kind of hand washing is often required when you are dealing with droplet infections. Another important thing which you have to understand is wearing gloves. So I have seen so many medical officers, they wear the same glove for examining all the patients. So you are protecting yourself? No. You are actually spreading the infections. You are having a false sense of security that this gloves is now your lifesaver. What it is doing it, this false sense of security is ensuring everything around you is now going to be contaminated. That thing will come to your clothes. You're going to reach for your phone. That gloves is the worst thing you can do. Remember, what is needed is gloves, great, but gloves should not be a false sense of security. So, so remember that gloves have to be used. They are not a substitute for hand washing. They, when you are touching anything which has got blood or mucous membranes, like now suppose I need to examine this child's mouth, and I need to examine for tonsils, I need to examine the rash, and I think there's a vesicle. So I will wear gloves, absolutely. But then I need to dispose the gloves correctly. What is required is that when I'm disposing the gloves, sometimes, so remember, this is a WHO triangle. Often people use sterile gloves for everything. No, so remember that when you're having direct patients, remember what in what indication the sterile glove is needed and in which indication you can use examine glove. For example, I'm using a phone, I'm writing the patient chart, I don't need gloves. But if I'm in contact with the blood or mucous membrane, yes, I will need unsterile gloves. However, if I'm doing a delivery invasive procedures, I'm starting a line, a central line, all those things, I will need a sterile glove. So don't misuse sterile gloves, and don't use gloves when they're not indicated, just for tapping a child. So you have to be, it's very important to know the right thing. This is a WHO triangle which was there. I would encourage all of you to have a look. So going on, so this is just a video, follow this. Why I've included this is because a lot of people who come to me, the way they are wearing and donning and taking off the gloves, they don't do it rightly, and which is what happens is that they end up touching the inside of the gloves when they are taking them off, and similarly when they are wearing them, they again touch the inside of the gloves, so they make the sterile gloves unsterile. So I'm trying to just show you what is the right way. Please, again, just Google it. You'll be able to find it. It's just a video we made for our hospital, and I will encourage you to have a look and just try to imbibe the steps. I've tried to include, if you can't hear it, at least see the underlying captions. You'll be able to understand, please. So see, he did a hand rub and hand wash first before wearing gloves. He did all the steps of hand hygiene. Then see, open the gloves along a pre-designated strip. So often I've seen is they just tear the glove and the glove falls down, becomes unsterile. Then wash your hands again. Now then you put it on a clean surface. Open the gloves. How you open the glove is, see, choose your hand size first. So, so remember, this whole part is sterile. Now wear the first glove as per your hand preference. If you are right-handed, use that. Do not touch the inside of the gloves. So sorry, bear with me. So use the first glove again. I'm sorry, it skipped the screen. Then see how he's putting it. He's not touching the inside of the gloves. He's only touching the folded portion. Then he insinuates the hand in the sterile part of the gloves. so that the outer part is not touched. And then he insinuates his hand inside and see how he's wearing it. So what is important is, as you can see, he did not touch the inside portion at this part, which is unsterile. And now your hands are sterile. Right? Now, another important thing to understand is how to take them off. Right? Now, how to take them off. So now you've examined a sick patient. So pinch the gloves at the base in one hand and peel it off. Okay, you are not touching the inside of the glove now. So at this time, the inside of the glove is contaminated with sputum or something. Put in a roll in the other hand. Now again, don't touch the inside. Insinuate the hand inside and put the glove on top of the other. Just roll it out. Now you see, you have not touched the inside part of the glove. You have just overturned it on itself and then discarded into the right bin. Other important thing was, so why I'm emphasizing on this is, if you do not, you as a doctor will be the one which will act as the carrier after examining 15 patients. If you don't choose the right mode of precaution, you will be the one spreading infection from one patient to the other. Another important thing is masking. Wear the right mask for the right patient. And remember, between patients, clean your hands, stay home if you yourself are sick, know whether antibiotics are appropriate, follow all the posted precaution signs yourself. You tell it to the patients, use yourself, use the right PPE, get yourself vaccinated. If there's an influenza season coming, get yourself vaccinated. Follow safe injection practices, keep environment clean, and educate patients and educate yourself. Some take home messages are that we have dealt with a lot of communicable disease, mode of transmission. We have identified the danger signs, emergency signs, how to triage, how to treat, how to intervene. Now we have talked about, how to stop infection. We have talked about the whole bit about communicable diseases. But what is important is breaking the transmission cycle in your clinic, ensure adequate isolation precautions are used, triage the sickest to save life, everyone. So it should not be that you as a doctor are using APLS, your staff nurse is using IMNCI, your some other teacher is using ETAT. All of you in the same clinic or dispensary or hospital should be using the same triage tool. So your sign should be same as the next one. Focus on immunization and document. So one saying which Kalidas had actually said thousands of years ago, which still pertains even today, which is Acharyat Padmadate Padam Shishva Samedhyam Sabrahmacharibhya Padam Padam Kalkramenacha. So what this means is that what you have learned today from Acharya, like senior professors and teachers like Sangeeta madam, is only 25% of your knowledge. If you go back from this class with only this much, you have only learned one third, or one fourth rather. Believe me, after 2 weeks, you would have forgotten it. One fourth is what you will go back, what all things which madam told you, which I told you, you will go back home and read. Just Google WHO ETAT, you will Google WHO gloves, and you will read it yourself. One fourth is from group study. This is what the NHRC has been doing now, that you are coming in a CME, but you will go back and read amongst yourself what it is in your center. And one fourth is what you do when you go back. So if only with this class, it will not help. If you do it, if you go through the whole way, learn, revise, do it, read yourself, that is the only way it will stay across. Thank you.
Thank you so much, sir, for the wonderful session. Uh, Sangeeta ma'am, are we open for some questions right now?
Yes, of course. Thank you,
Okay, ma'am.
Romit,
Thank you,
for
ma'am.
for taking up. This was a vast topic, actually, very difficult to cover it in a short time. But I think you gave the essence of it, and the participants found. I hope they found it useful. It is very important. Sometimes children actually. they can deteriorate fast and they are not able to communicate their problems very well. So it is for us to see, and there may be a lot of misbeliefs also, the parental concerns, anxiety. So there are a lot of things besides the illness that works in children. So for their optimal management, we need to be careful about this. If there are any questions, you can write in the chat box. Dr. Amit, you are here, no?
Hanji,
Uh,
ma'am.
take. And today was the last session of the third series. Uh, Dr. Amit, we've had a marathon of webinars. This was, in fact, a 36th webinar.
Wow.
So I think uh, this series, this was the third series, and today is the last day. Maybe you can also suggest. I will request you all to write a topic suggestions for us, for the for us to continue, whether you want to continue it or not. That also we would like to know, whether you found it useful. We've been trying to do our best efforts to identify the best resource persons for you. So I think many of these topics were actually very, very big. Even, I had made a lot of case discussions, but, it's difficult to cover in 45 minutes to 1 hour all these sessions. Foley's catheter, there is a question.
There is a question
Any
on
update
UTI,
on
ma'am. I think
recurrent UTI? Can you tell the indications for prophylaxis in recurrent UTI?
ma'am, so essentially, I would encourage all you guys to. I'll be speaking only in pediatric context because recurrent UTI is something which can happen to a 60-year-old woman. It can happen to a 40-year-old man. It can happen to a 1-year-old child. In every age, the treatment and approach will be different. So what I will be telling you is more from a pediatric context. So from a pediatric context, I will strongly recommend, again, not just for this question, but any question you have. There is Indian Academy of Pediatrics. They have a lot of STG, standard treatment guidelines. Just Google them and you will be able to get that. So specifically for your question, so recurrent UTI is when there's 2 or more levels of febrile UTI, when the patient has the first UTI less than 6 months of age, when there is a presence of a known risk factors. For example, if the patient has got VUR or this patient has some other problem alongside. So all those things will be the ones where they have a chance that recurrent UTI occurs. And similarly, when the patient has a patient who is toxic, patient less than 3 months, having very high grade fever, who is sick looking, dehydrated, renal angle tenderness, patient goes into AKI, all those are complicated UTI and features. So depending upon the age, you can either start cefixime. So what I always advise is, first, what Mehmet also said, there is no one antibiotic for every child. You have to do urine microscopy and culture, and you have to know what culture you are taking, whether you're taking a midstream void sample, so then you need 10 to the power 5 CFU per ml. You're doing a urethral catheterization, that's a different 10 to the power 4. Doing a suprapubic aspiration, then any number of CFU is important. So learn to implement. So just saying that one patient, like you have taken my urine sample, I'm normal, I'm absolutely eating, dancing, playing, somehow my sample grows E. coli 10 to the power 5. That doesn't mean I have an infection. It is has to be interpreted in the fact whether I have a systemic symptoms, whether it's actually having symptoms of UTI, urine microscopy is positive, and then concomitantly the patient has something positive. Then depending upon the age, you can either start cefixime, like Mehmet said, 10 mg per kg, 8 to 10 mg per kg in 2 divided doses. Cephalexin is a good drug. Often there are some drugs like trimethoprim and cotrimazole is used, but they are not used in patients which are having G6PD or less than 3 months. And so in those infants, cefixime is or cephalexin is a safer option. Cephalexin is a good drug for uncomplicated UTI prophylaxis as well. So again, all those things you can do. But first of all, important thing is be very careful in knowing that whether you are actually treating the right thing. And another thing is identification of the cause. Why should a person have UTI in the first place? Often these children, especially less than 1 year, you need to get a renal bladder ultrasound. You need either a MCUG, that is micturating cystourethropy, to identifying whether the patient has basically a vesico-ureteric reflux, and often you need a DMSA scan to see whether there's any structural disease, which is normally done after few months of UTI. So again, there's a whole approach there. I would recommend. I don't know how much of what I said you got, but what is required is approach systematically, identify whether you're treating the right disease. Is it in fact UTI, or is it a complicated? Is it just a contaminant from the surrounding flora? And if it is, whether it is a complicated UTI or is it a recurrent UTI, and then only then start prophylaxis depending upon age, culture sensitivity, and whether the patient has G6PD or not. All those things, because you don't want to start stuff like cotrimoxazole, trimethoprim, or nitrofurantoin in a G6PD child. You will have a crisis. So it is important to know and identify thereof. Thank you.
Thank you. Romit, just taking further, one is that prophylaxis he has already talked about. Then second, the common practice that we see is, we try to treat asymptomatic bacteriuria in adults, you know, uh, unless there are symptoms. You don't need to treat just because you have grown something. This could be a colonizer. This could be a contaminant in the, and particularly if you grow polymicrobial growth in the urine culture, you should not treat this is a contaminant most likely, so not needed. So similarly, I was giving you the example of in situ tubes. Similarly, patients on Foley's catheter, they are at risk of developing urine infections, yes, right, but that does not mean anyone who has got a Foley's catheter needs an antibiotic. The practice, the case that you have mentioned in the chat box, person with indwelling Foley's catheter giving nitrofurantoin 100 milligram OD for 20 days every month as long as Foley's is needed. Is this right? No, not at all. Even with Foley's catheter in place, only treat if there is a flank pain, fever, patient is having. Just don't go by कि Foley's catheter है या कुछ grow हो गया. Only treat if this significant growth. So again, I was to do this, but because of the time, I could not touch on this. But this is one area. So sometimes they even also say, don't get unnecessary urine cultures in adults. If you do unnecessary cultures, you will find something on the, you will grow something on the culture, and there would be a temptation to treat that. So if you want to reduce this, do this only when there are indications for that. For example, in pregnancy, yes, if you find there is a bacteriuria, and but the patient is not having symptoms, still you have to treat. There are few exceptions for this, but by and large you don't have to treat asymptomatic bacteria. Then there is, I think, I hope I answered your question. Then there is a question about primary healthcare making their own antibiotic policy. Yes, it is. This antibiotic, you don't have to cut and paste or adopt the policy, but for a particular level of a healthcare, primary care, CSC, or a district hospital, more or less, it would be different according to the levels, but more or less across PSCs, across CSCs, we don't see much changes. But you can also make these, the you have the you can take the adopt the antibiotic policy, but tailor it to according to your requirement. It just says about the rules for prescribing, and you have a limited number of antibiotics at the PSC level or a CSC level. So you see that the antibiotics that you have in the list or in the formulary are from the excess group. So some people are also using that traffic signal approach: green, yellow, red. Green is for the excess group, yellow is for the watch group, and red is for the reserve group. So accordingly you can develop who will prescribe, for how long it will be prescribed, and eliminate watch group, especially from your OPD list. This will be helpful. Then I think there are no specific questions. You can write down the topics here. Yes, after COVID period platelet, we had dengue sessions where particularly these platelet counts were discussed. Maybe you can go through those YouTube recordings that will help you. By and large, platelet dropping down to 1,10,000 is safe. Even we have seen platelet counts as low as 20,000, and if the patient did not have any bleeding event, patients recover. Even people have gone below 10,000 also, and they have recovered without any transfusion, platelet transfusion or other measures. All you have to see is that the patient gets the supportive treatment, and you don't give any medicine which increases the bleeding risk in these patients. Antibiotic medicines. Can make a session on antibiotics, medicines, arthritis, many other topic. You can write down the. You can also write these suggestions in the feedback form. We will be looking at the feedback as well. And since this is the last session, I would request all of you to give feedback. In general, not many people are providing the feedback. I see more than 200 people who have taken the pre and post test, but the feedback was given around by 80, 90 people only. So this is actually, we will be looking at it, evaluating this, how is this going to help you in future. um, uh, and I believe there are many CHOs also joining, nurses staff also joining. You can also provide your suggestion for the topics, so that we can address this. Now there is one question about restricted antibiotic form can be used only for specific antibiotic, and when. This is usually these restricted antibiotic are kept for reserve antibiotics and for the high priority watch group like piperacillin, imipenem, carbapenem, vancomycin. So these are usually reserved. So these restricted antibiotics, they have to be ordered by at the consultant level or the senior medical officer level. Uh, uh, the idea is we are trying to restrict, we are trying to make it that these drugs, reserve drugs, are used appropriately, as a last resort, not as a first resort, just because you feel that the patient was sick. There is a YouTube link in the chat box. Those you can note down that URL of that YouTube. You can watch any of these sessions at leisure. When you have more time, you can go through them as many times as possible. Give us the feedback. I think you have all done the pre and post test. Once again, I would like to mention here that those of you who attend through the session and give both pre and post test will get the certificate. And usually they work at back end, and it takes 10, 12 days, 15 days time to send this certificate. So please be patient. You will be getting it And please ensure, many of you keep saying that you gave both pre and post, but you haven't got it. But the reason could be that you may have used different email ID. So for us, we the computer recognizes the unique IDs, so they can't make out if you use another email ID. So that's one of the common reason why you don't get it. Antibiotic lecture for OPD, IPD patients, yes. This is OPD is called outpatient stewardship. There are very important gains coming from restricted use of antibiotics in outboard, because we see large number of patients in the OPD. And if you look at the prescription practices, 80 to 90% patients get antibiotic, whereas if you look at the morbidity profile, you will not find as many infectious patient as the number of प्रिस्क्रिप्शंस विद एंटीबायोटिक। तो इसलिए बहुत ज़रूरी है कि एंटीबायोटिक्स ओपीडी में देखभाल करके ही प्रिस्क्राइब करें, क्योंकि उसमें आपके पास 100, 200, 400, 1000 पेशेंट आ रहे हैं। सो यू विल बेनिफिट मोर इफ यू आर प्रूडेंट इन आउटडोर डिपार्टमेंट। और उसमें दो मेजर इलनेसेस हैं, इम्पॉर्टेंट पेशेंट्स हैं जिनको एंटीबायोटिक ऐसे ही प्रिस्क्राइब किया जाता है। सोर थ्रोट में पोस्ट वायरल कॉफ 2 हफ्ता 3 हफ्ता रहती है वो कॉफ, but this is not necessarily an infectious cough. So don't unnecessarily try to treat this cough with antibiotic. And at the first place also, you don't need these antibiotics for sore throat, except that streptococcal pharyngitis. You can, I showed you that picture. When you examine it, if you find the pus point, it tells you clinically also, you can make out that this is the patient who needs the antibiotic. Even in sinusitis, even in rhinosinusitis, you don't need to give antibiotic. First 10 days, if there is no improvement, then only after 10 days, if you don't see any improvement, then only antibiotic is needed. Again, this rhinosinusitis is viral in nature. Only if it is not improving, staying beyond 10 days, or there is a double sickening. Initially this rhinosinusitis was there, patient started improving and then gets it again, then only antibiotics are needed. Otherwise, even in sinusitis, many people have this idea कि sinusitis में तो देना ही पड़ता है. No, not needed. There are criteria for prescribing antibiotics for rhinosinusitis. I think if there are no more questions, we can.
Okay, ma'am. So thank you so much everyone for being a part of this webinar session. Given that it's the last session of third series, the further intimation of the fourth series would be conveyed to you all. Before concluding this webinar, I would like to inform you all that the feedback link, post-test link, along with the YouTube link has been already shared in the chat box. You can please go through it, and all those who attempt both pre and post-test would be offered the participation certificate. There is no qualifying marks as such. You just need to attempt both the tests. And also, in the end, I would like to thank all the participants, our guest speaker, Dr. Sangeeta Sharma ma'am, Dr. Romit Saxena sir, for being a part of this session. Extended gratitude to our executive director ma'am and advisor sir for gracing this webinar session. Thank you so much everyone for being a part of this.
Shreya,
Thank
I also want to thank them, NHSRC, new people who had been working behind the scene, Ranjit Mandal, Shreya, Siddhi, Deepika, Dr. Jayan Srivastav, now Dr. Bhatni, for their full-hearted support for this program, and the executive director, Dr. Pragya Sharma. Um, uh, uh, Please accept our thanks from DSP RUD and my personal behalf. Thank you.
Thank you so much, ma'am. Thank you, everyone. Thank you. Have a nice evening.